Hello, I'm Dr. Dan Robinson and you're listening to the Physical Performance Show. I'm an ENT surgeon that works on the Gold Coast with a primary interest in nasal obstruction and surgery for treatment of nasal obstruction. Today we are talking about navigating nasal obstruction.
And the winner is...
Failure is not an option.
I've had my ups and my downs.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Welcome to the Physical Performance Show, brought to you by the Physical Performance Show's Learnings membership and Pogo Physio's online telehealth physiotherapy consultations. I'm Brad Beer, sports physiotherapist and exercise scientist by trade and training and founder of Pogo Physio. Each week, we'll bring you the latest and greatest information and inspiration designed to help you perform at your physical best. And of course, we do this across a range of different episodes, expert editions, interest editions, featured performers, and coaches' corners. And keeping the expert edition theme running for 2021. Today, I'll share with you a conversation I recently had with Gold Coast-based ear, nose and throat surgeon Dr. Dan Robinson on all things navigating nasal obstruction. Now, if you tuned in last week to episode 252, you will have heard Rory Darkins, positive psychology researcher and mental skills coach, share around the importance of nasal breathing for health, well-being and performance. So it's timely that today we bring Dr. Dan on to share around how to navigate nasal obstruction. Now, 1 in 3, as you'll hear today, people experience nasal obstruction. I was certainly one of those, having lived with nasal obstruction for several decades before taking action late last year with Dr. Dan Robinson and now enjoying better night's sleep and overall feelings of better well-being. It's a super important topic that unfortunately doesn't get a lot of airtime, with many people seemingly suffering in silence. Get set for the learnings today as Dr. Dan Robinson shares around the different types of nasal obstruction, how nasal obstruction presents in both children and fully grown adults, the different types of obstructive sleep apnea, central and peripheral, and how each of those presents, the physiology of breathing and why when we exercise, most of it occurs through the mouth, yet that's reversed when we sleep, with the bulk of breathing happening through our nose. Dr. Dan shares around nasal anatomy, including the nasal valve and why it is so important, and importantly, how to treat nasal obstruction and the treatment pathway, or sieve as Dr. Dan Robinson refers to it as, that exists all the way from nasal spray through to devices, through to surgical procedures. So this is a topic whether you're into performing at your best across endurance sports or just optimizing your well-being, that you will need a pen and paper for and a keen ear to determine if you are experiencing any nasal obstruction and the resultant impact that may be having on your well-being and health. So here is Dr. Dan Robinson on this expert edition, Navigating Nasal Obstruction. Dr. Dan Robinson, welcome to the Physical Performance Show.
Thanks for having me here, Brad. It's a pleasure to come on.
Dr. Dan, I actually, circa 7 or 8 weeks ago at the time of recording, underwent a nasal obstruction procedure with yourself, and it's really, for the first time in a decade plus, I can breathe through my nose, and it's been a... pardon the pun, but a breath of fresh air for myself, and thinking about how this is now likely to affect my health and hopefully my sporting performance, I thought this would be a great topic to spread to the wider audience, which are predominantly endurance athletes, coaches and practitioners.
Yeah, and it's a very common story that I see and hear at work, and also one I can relate to myself. I certainly noticed that after I had an operation on my nose, my performance and quality of sleep went up quite dramatically for me. So that's a great story and a very, very common one.
Dr. Dan, your background, to bring us into context with a day in or a week in your life at the moment, and your medical background, how did it all start, and how did you get this interest in this line of work, develop this interest?
Well, I'm an ear, nose and throat surgeon with a subspecialty interest in nasal obstruction and functional as well as cosmetic rhinoplasty, and I developed this interest by recognising how much morbidity a blocked nose causes people in society. So a lot of people don't notice that they've got a blocked nose, and they can seek medical attention for problems such as struggling to get good quality sleep or lack of physical performance. And then when their blocked nose is improved, you're able to alleviate a lot of morbidity and really improve someone's quality of life. And that's really what drew me to this corner of medicine, and also what I do most of the time, which is improving the breathing through the nose through operations. It's immensely rewarding, and it's also very challenging.
And we featured a colleague of mine in the physiotherapy exercise science space several episodes, or quite a few episodes ago, James Fletcher, around the science of breathing. And James issued a physical challenge, which was to tape your mouth up next time you go for a run and see how you go. And I developed anxiety because I just couldn't get air through my nose. And at that point, I thought, I think I need to get this checked out. And that's obviously how I ended up with yourself. And it's been a game changer.
That is a very extreme method of determining if you have a blocked nose. If people talk about ability of breathing through the nose, 1, can you breathe through your nose when you're asleep? 2, can you breathe through it at rest? 3, light exercise, and then 4th, going for a run. The reality is there's very few people that would be able to complete a run of much distance with their mouth taped. Yeah.
So James set the bar high.
Yes, that's very high. Yeah.
You mentioned that word morbidity. Can you just expand on that a little bit around, you said that it's incredible how much secondary morbidity the blocked nose can cause people in society.
Yeah, it's humans are at birth obligate nasal breathers, and we know this with young children that have a blocked nose on both sides. They die unless you open up their nose within about 10 days. It's relatively rare, but following on from that, as we develop, our body develops workarounds associated with having a blocked nose, and they are not ideal from a physiological state. And so not breathing through your nose effectively causes specifically problems associated with sleep, as well as can change lung capacity as well. And people will notice that their ability to perform exercises which require a very large lung volume are improved if their nose is if they can breathe through their nose. The morbidity that it causes in society is enormous. Approximately 1/3 of the population have nasal obstruction in some regard, and the burden on society is very large.
And obviously, with your skill set, that must frustrate you to some degree, that there's not a greater awareness of not because you're looking for work, quite the opposite.
Yeah.
You can't get a holiday, but knowing that there's such great need.
It is surprising how few people realise that they actually have a blocked nose, and that is what is causing a lot of their problems. The classic that I see at work is the patient that has obstructive sleep apnea and is certainly not overweight. They'd be around your sort of build, Brad, and they have obstructive sleep apnea purely from a blocked nose. And then obviously open up their nose and their obstructive sleep apnea gets better. Not necessarily saying it goes away, but certainly does get better and is more easy to manage.
I think you grabbed the attention of every athlete out there when you said that you can see a change in lung volume / capacity.
Yeah. That's something I haven't actually measured it myself on my own personal experience, but I certainly noticed it. And when I do exercises that are more demanding from a lung point of view and just need that PEEP and large FEV1, FVC, I notice an improvement. And a lot of the patients I've operated on that are professional or semi-professional athletes and also retired NRL players, they have all noticed the same thing. One specifically set a PB in a half marathon by over 10 minutes after he had his nose opened.
You'll have many runners lining up on your doorstep, Dan. We're recording this on the Gold Coast, and arguably the leading cyclist in the area, if not one of the best nationally, he commented to me after you operated on his nose that he knew he had a problem when he was on the wind trainer at home, and he went to eat a bit of a muesli bar and choked on it and couldn't breathe, and he realised that he probably needed to do something about it. So that's even at the top echelon of sport.
Yeah, that's a very extreme example of having a blocked nose. If you're having issues associated with life and death because you can't breathe through your nose because your mouth's full with a muesli bar, I think you've got a pretty serious problem. So it's,
Well, it's a good story.
Yeah, it's an excellent story. Yeah.
Dan, you mentioned workarounds. If you do have a blocked nose post that obligate period as infants, what workarounds are there?
Your body will essentially get you to breathe through your mouth, and how that manifests is specifically with you sleeping with your mouth open as a child, and that's very common for us to see as ENT surgeons. And then they'll also snore, drool, and then also have problems associated with eating. So in the extreme examples of a blocked nose in the paediatric population, I see patients who cannot eat dinner with their mouth closed because they cannot breathe through their nose. In adults, the workarounds are similar. It's also the body's mouth opens when you go to sleep, and then that leads to snoring, and then also posturing of the mandible, which is not ideal for dentition. And then issues associated with sleep apnea. And patients will often also toss and turn side to side at night. It's very common. I see patients that say they have a blocked nose that oscillates from the right side to the left side, and it's called the normal nasal cycle. And those patients will find themselves sleeping on their right side for 6 hours, then on their left side for 6 hours as the normal nasal cycle changes throughout the night. Now, the nasal cycle refers to engorgement of the inferior turbinates. We haven't touched on the anatomy as yet, but the inferior turbinates are two scrolls of tissue that are quite vascular in the nose, and every 6 hours one of them increases in size. And if let's say for example the right one increases in size, that means the left one is decreasing, so your dominant nostril becomes your left nostril, and then 6 hours later it reverses, and that's a part of the normal physiology of the nose. So adults we see with a blocked nose, you don't see it as commonly in kids, but in adults, they'll say, I just feel like the nostril that is blocked changes side to side all the time, which is a very common complaint in my practice.
Yes, so there's, I've written down a few there. In children, sleeping with the mouth open, drooling, having trouble eating with the mouth being closed, snoring, and then as you said, into adulthood, this the nasal cycle, the obstruction shifting side to side, and then you said posturing of the mandible. Can you expand on that, Dan? So
there's patients will sleep with their mouth open and try to protrude their mandible subconsciously, so anteriorly, and although it does help the patient sleep that night, it's not ideal from a development of teeth point of view. It's an area that dentists talk about all the time. When your tongue can't sit in the right position because you have your mouth open at night, then your dentition is poor, and you suffer from malocclusion, and can also lead to hypoplastic maxillas, which need maxillary expansion. That's not a procedure which I do, but I certainly see patients to have their nose opened so that they can then go and have a maxillary expansion splint, and those problems come from having a blocked nose.
Does that mean reduced jaw size?
Yes. It does mean reduced jaw size, and specifically highlighted on the maxilla, so the upper part of the jaw.
Upper part of the jaw rather than the mandible.
Yes. Yeah.
The bottom bit. Dan, so we've established that it's very common, nasal obstruction. We have touched on a few of the signs to look out for. Just on sleep apnea, I think it's a term that most people are aware of, but maybe a little misunderstood. What's the definition of sleep apnea, Dan, and what can people specifically look for there?
So sleep apnea is characterised by problems associated with the way you are breathing during sleep, and it's divided into obstructive sleep apnea, which is either central or peripheral. We'll just talk about peripheral because central is involved in neurological causes. Peripheral obstructive sleep apnea, patients are subconsciously, whilst asleep, attempting to take a breath, but they can't. And when they can't take a breath, they then go through a period of either hypoxia or hypocapnia, which is where they are not breathing, and then all of a sudden they are kicked out of their deep sleep, and they wake up and take a breath in response to the subconscious afferents that cause patients to breathe whilst they're asleep. So obstructive sleep apnea patients will typically snore. Their snoring will be characterised by having long pauses followed by startling awake, and patients will also have very restless sleep and wake up in the morning feeling very tired. Often these patients also feel hungover all the time, and if they do exercise, they will struggle to recover from it, and their recovery requirements will be much longer than most people.
And this, just to drive home, can be driven obviously by nasal obstruction.
Absolutely. So obstructive sleep apnea, in almost everyone I see starts with a blocked nose. There are occasional cases I see where patients have obstructive sleep apnea without a blocked nose, but the vast majority have a blocked nose.
And demographics, Dan, is there any, this can affect anyone, or are there certain demographics or
From an obstructive sleep apnea point of view, it's commoner in males. It's got an association with a neck circumference of over a certain size. I believe it's 44 inches, and also associated with large waistline, and essentially patients that are overweight. And the older you are, the more likely you are to have it as a male. It's also got other associations such as patients that take sedative medication or heavy drinking, lack of exercise. It's less common in patients that are really fit, but it certainly still happens. And when those patients have it, it's usually a single cause as opposed to a multifactorial cause. So patients may just have a blocked nose that's causing their obstructive sleep apnea, or that is the dominant cause. So when that's fixed, they feel a lot better.
Dan, the role of breathing with sleep at rest and exercising, can you touch on the role of breathing?
So we'll start off with exercise first, because as you've already highlighted, you had a very hard challenge for trying to breathe through your nose. Very few people will be able to breathe through their nose while they're exercising. They may be able to partly breathe, but the majority of airflow happens through the mouth. So in relation to the role of nasal breathing during exercise, some people it's ideal that you can breathe somewhat, but you don't have to be able to breathe entirely whilst exercising. Now, whilst sleeping, that is the reverse. Your body wants you to breathe through your nose when you're asleep. And there's a few hypotheses behind this, but the one that I personally feel is the most correct is that the nose is a relatively static structure when compared to the oral cavity and the oropharynx. So if you imagine the tongue flopping around while you're asleep and your cheeks and your lips, that's a lot of mass of tissue with which air needs to go in and out. Whereas in the nose, you have a septum in the midline, two turbinates on either side, and a lot of it is held there by either cartilage or bone. So it's a much more static structure, and that's the theory that I hold to as to why humans want to breathe through their nose whilst they're asleep, because you don't need as much muscle tone or specific posturing, which we've mentioned before, to allow you to breathe through the nose.
And then the role of exercise at rest. Dan, the role of breathing at rest.
At rest, breathing through your nose does improve your recovery. And if you, while sitting to this podcast, just take a really big breath in through your nose and hold it, you will feel a lot more energised. You won't get as dry a mouth associated with it. And its role really at rest is associated with recovery.
So with recovery, Dan, before we met, I did have my trusty 2000 edition Frank Netter anatomy textbook out, just reviewing some of the anatomy. Can you just paint some broad brushstrokes around the anatomy of the nose? What's in there? You've touched on a few structures already.
Sure. So the nose is obviously a left and right nostril there, separated by the septum. Now, septum is predominantly cartilaginous. There is a small aspect of it that is membranous, and then all the way at the back there is a bony component. But the component that I most commonly see in the septum that causes problems associated with breathing through the nose is a cartilaginous part of the septum, which divides the nostril into the left and right cavity. You can look at your own septum if you tilt your head back in the mirror and shine a light up your nose, and if you want, also push on your tip and elevate your tip backwards. This will give you a relatively good picture at the first 8 to 10 millimetres inside your nose of the septum and whether it's sitting off to one side. Anatomical problems with the septum are incredibly common. There was a statistic quoted about 5 years ago that said that 96% of the population have a bend of their septum. I have seen thousands of noses, and I have not seen someone in that final 4%. I've never seen someone with a dead straight septum. Everyone has some degree of bend in the septum, and that's got to do with the fact that no two sides of the human face are exactly the same. That being the septum's embryological remnant that obviously sits right in the middle, so it's going to get pulled to one side or another associated with any abnormality or any difference in size between the left and the right. Moving on with the anatomy, the two turbinates, which are on either side of the nose, are vascular structures which go through what we were referring to before called the normal nasal cycle, where one swells and the other one decreases in size. They also serve important purpose in the form of sweeping material from the front of the nose down to the back of the nose, so the ciliary clearance of the nose itself. So that's not the paranasal sinuses, but the nose itself is formed by the inferior turbinates. And they also perform another important role. That's in sensation nasal airflow. They sense change in temperature that goes into the nose, and a cooling of air that goes into the nose gives a sensation of nasal airflow. This is also sensed in other parts of the nose, but the turbinates certainly do also perform this function. And then finally, from a blocked nose point of view, the other factor which I see as very important is called the nasal valve. Now, the nasal valve is the side wall of the nose. If you follow the septum up to the tip and then go out to the side of the nose, the nasal valve there is essentially the rim of skin that sits over the nostril. That's called the external nasal valve, and then a little bit more superiorly is the internal nasal valve. And in my practice, I see a lot of patients that have nasal valve collapse, where that valve, every time they go to take a big breath in, just slams down shut because it's not strong enough for the airflow for air to flow in that nostril. There are some other factors associated with nasal obstruction which may be causative, such as nasal polyps or rhinosinusitis, and then very rarely in adults, adenoid hypertrophy. So adenoids are a lymphoid tissue at the back of the nose, very similar to tonsils. They go through a process of enlargement at the age of 2, and it's a site of B-cell maturation. And then at the age of 7, they start to involute, and the vast majority of adults don't have appreciable adenoids. So I don't see adenoids as a major contributor to problems with breathing through the nose in adults. So it's really septum, turbinates, nasal valve, and plus or minus rhinosinusitis.
And that, thanks for the anatomy of the nose 101 there, Dan. That internal nasal valve, so that's not visible to the from the outside. That's
the internal nasal valve is visible if you stand in front of the mirror and take a big sniff in. You have a collapsed nasal valve if you are getting a pinch approximately 7 to 10 millimetres above the rim of your nose. That's the site of the internal nasal valve. So when you look in the mirror, imagine the structures under there form the internal nasal valve as an approximate. It's very difficult to see the internal nasal valve unless you're seeing an ENT surgeon with a camera in your nose from an internal point of view.
You're listening to Dr. Dan Robinson, ENT Surgeon, on this an expert edition around all things navigating nasal obstruction. Today's episode is brought to you by Pogo Physio's award-winning online telehealth consultations. If you are an endurance athlete struggling with bone, tendon or joint-related concerns, then rest assured our online 45-minute consultations can assist you in getting back to your physical best. We conduct these weekly with athletes both inside the states of Australia and internationally, and enjoy seeing people get back to their physical best via this medium. To schedule your 45-minute online consultation with myself or any of the Pogo Physio team, jump over to pogophysio.com.au/telehealth. Support for today's show also comes from our Learnings membership, where for just $5 per month, you can gain access to our back catalogue of live stream events and also all future live stream events planned. Last year, we hosted Dr. Stephen Seiler, forefather of all things polarised training, for a very popular live stream event that attracted hundreds of practitioners, coaches and athletes worldwide. We also later in the year hosted Dr. Shona Halson, recovery science expert, around all things optimising athletic recovery, which, just like Dr. Seiler, was incredibly well sought after and popular. Tickets for our live stream events are usually $49 per person. However, for the Physical Performance Show Learnings members, you can receive access for just the $5 per month. Now, to pledge your support, to assist with the production of the show, you can jump over to Patreon, just search the Physical Performance Show. Of course, there's no obligation or expectation, but certainly been enjoyable to see the support that the show is receiving. As we always say, podcasts aren't free to produce, they are free to download, and any support does make a big difference. So thank you to the patrons that have jumped on and supported the show thus far. For now, let's jump back with this week's expert edition featuring Dr. Dan Robinson on the all-important topic, navigating nasal obstruction. Dan, I recall when I first consulted with you that you mentioned that noses can drop. Is that this internal nasal valve?
So what noses drooping is actually the effect of gravity on the tip of the nose. So now gravity on the tip of the nose causes the scroll joint, which is actually located at the internal nasal valve, to separate. As it separates, the tip of the nose droops. As it droops and becomes ptotic, nasal airflow has to take a bigger bend around a corner, and it gives patients a condition called senile nasal obstruction. So essentially nasal obstruction of elderly patients. And these patients have a scroll joint that's separated associated with gravity, a ptotic nasal tip, and then they also usually have some degree of internal and external nasal valve collapse.
So is that only typically a condition of the later years?
The drooping of the nose is usually a condition of the later years, that's correct. It can occur in younger patients if they've had significant trauma of the nose.
And rhinosinusitis, what exactly is that?
So sinusitis is inflammation of the paranasal sinuses. It's characterised by either polypoid or non-polypoid pathology. So the exact etiology of rhinosinusitis is not understood, and I personally am of the opinion that we probably won't find the cause for rhinosinusitis, but it manifests in the form of a blocked nose, runny nose, postnasal drip, hyposmia, facial pain and pressure in varying quantities, and also has CT scan findings consistent with fluid or opacification within the sinuses. It's something that I see a lot of in my ENT practice, and as a broad strokes sort of approach, polypoid rhinosinusitis is usually associated with patients that have upper airway conditions such as asthma or eosinophilia, not exclusively, but usually, and then non-polypoid is usually not associated with asthma, eosinophilia, or other airway diseases.
And how common is this rhinosinusitis?
The exact number is very hard to determine because this is slightly off topic, but the data on rhinosinusitis is very dirty, where people claim to have rhinosinusitis when in actual fact what they've got is either a migraine or a blocked nose or allergic rhinitis. So unfortunately we don't know, but we think it's somewhere around 2 to 5% of the population with a reasonable amount of geographic difference.
Dan, should we talk about what can be done? So I think we've established that it's very common, nasal obstruction. We've established that it has health consequences and performance consequences. Is there anything you want to add on to what you've already shared on that side?
Yeah, I would also add that if people feel like they have a blocked nose and they can't breathe through their nose, then that's an issue. It's often overlooked for years and years, but it is something that on the whole is very treatable. And if you feel as though you have a blocked nose, you should really think about treatment for it. And if we run through the treatment sieve for a blocked nose, it starts off with nasal sprays, so a saltwater wash, which you can get from the chemist, and an intranasal steroid. There are some intranasal steroids that are available over the counter. I don't want to plug a specific drug myself. And then if they don't work, then there are others which your GP can prescribe that are very effective. Intranasal steroids only come into effect and are effective after using them for 6 weeks in total. So it does require a fair amount of commitment. You will notice a change in the breathing through your nose if they're going to work after 3 weeks, but their maximum effect isn't noted until 6. Beyond using nasal sprays, and there are some other products that you can trial at night to see if they improve the breathing through your nose, the commonest one being a Breathe Right strip, which sits at the junction of your internal and external nasal valve and stents your nose open. Another product which you can trial to improve the breathing through your nose is trialling a snore bend, which is essentially 2 tubes that you put in your nose to breathe through at night. And they can be very effective at facilitating sleep whilst contemplating whether you want to have surgical intervention. From a surgical point of view, the treatment of nasal obstruction does depend on where the obstruction is. For some patients, a turbinoplasty will be enough, and turbinoplasty means reducing the inferior turbinates on both sides. This is a very safe procedure to perform and very good at opening up essentially the lateral wall of where patients breathe. Septoplasty, for me, has changed dramatically. So septoplasty is where the cartilage in the middle of the nose is straightened. I very rarely perform this procedure because I did not feel that the results were where they should be. So for me, septoplasty is a procedure that I only perform when patients purely have a bend down the back of their nose, so not in the anterior 1 centimetre. And the commonest operation I perform is called a functional rhinoplasty. So functional rhinoplasty involves essentially taking out the septum and then putting it back in with cross-lamination between the upper lateral cartilages, which are just under the nasal bones, all the way down to the tip and securing that to the maxillary spine. I also do a turbinoplasty at the same time and, as required, improve the nasal valve or improve the ptosis. From a success point of view, we purely look at breathing through the nose. Just over 97% of the patients that I operate on have an improvement in breathing through the nose after that operation. Now, if we look at how that translates, so that then has to translate into a change in how the patient is. If we take that 97% of patients and then look at what happens to their quality of sleep, every last one of them has an improvement in the quality of sleep. They feel more rested, and a lot of patients come back to me after a few months of going through what is referred to as catch-up sleep, and they suddenly say they don't need to sleep quite as much as what they used to. It's certainly also been my experience. After I had a functional rhinoplasty, my sleep requirement dropped by about 10 to 15 minutes per night, which was pretty significant.
Dan, and I can certainly attest to the improvement in my sleep post the procedure, and I had the functional rhinoplasty and the turbinoplasty, mouthful.
Yes.
And the purpose of the functional rhinoplasty, like as you say, you take the septum out, completely out, yep, and then
Yes.
pop it back in, is to, if it's not to realign, what's the purpose of that part of the procedure?
The purpose of it is to realign the septum and maintain strength of the nose. So I just have to go back to what a septoplasty involves. Septoplasty involves removing the bend in the nose and then, in the septum, and then suturing the septum to where you need it to be. Now, if I look at failures in septoplasty, the failure occurs when the bend is at the front of the nose. You don't, as a surgeon, want to remove the cartilage that's at the front of the nose because if it is removed from the front of the nose, then the patient has no support in their tip, which causes very significant problems associated with ptosis and the senile changes, which we were talking about before. So I perform a functional rhinoplasty by taking out the septum completely, and even if the bend is at the front of the nose, it doesn't matter because I then cut that septum, which I've removed, into straight planks, for want of a better term, and I use them to then reconstruct the patient's nose. Now, if someone has had a really smashed nose, it's very common for me to use rib to do this. I would do approximately 4 or 5 ribs every week where you're then utilising rib cartilage to reconstruct the patient's nose because their septum is probably not going to cut the mustard when it comes to reconstructing their nose and giving them a lasting result, which should last the rest of their life.
So the turbinates don't tend to re-engorge in size or grow back?
It's very rare using the technique I use for turbinates to regrow. I do have a regrowth rate of just under 1 in 2,000. And it was the same patient twice that had very significant allergies. And after doing a turbinoplasty, their turbinates regrew at somewhere around 18 months to 2 years after the operation, and it's happened twice on that same patient. So unless patients have very significant allergies, it's very unlikely that the turbinates will regrow. Caveat to that is performing turbinoplasty in children, which I do. Doing a turbinoplasty in children, the turbinates can regrow as they go through puberty or significant hormonal change. I also am very against doing functional rhinoplasty in children, but for other reasons. But I'm very happy to do a turbinoplasty in children. It has great success for several years, but they can regrow when they go through their puberty.
And once again, the signs of that will be, as you've already shared, things like sleeping with the mouth open, difficulty eating with the mouth closed, drooling, snoring.
Yes, absolutely. They're the signs that the child will have. They can also have very significant dentition problems, which can occur at a variety of ages, but usually about the age of 10, as another manifestation of their blocked nose.
Dan, so you've just shared around this, as you labelled it, the treatment sieve for nasal obstruction, and it started with the nasal sprays. Just looping back to that, you said the maximum effect will be realised at circa 6 weeks of use. I imagine, though, it's not something that you do for your lifetime, continue to use sprays. Or is that sometimes a plausible pathway for people?
That is a very palatable pathway for some people, and they're happy to use a spray, especially if they are going to have to be on a spray anyway. So patients that I see that are happy to stay on sprays are patients with severe allergic rhinitis, and which is otherwise known as hay fever. If you have severe hay fever, surgery is not a cure for hay fever. It can make it easier to manage, but it is not a cure. So those patients will need to be on a spray anyway, and if the spray manages the hay fever or alternatively underlying inflammatory conditions like rhinosinusitis, then it is a very viable option. But the flip side is a lot of patients try the sprays, they say, oh, well, it sort of worked, but now I just don't want to use the sprays anymore. And that's entirely reasonable to go ahead and do an operation, because those patients will potentially not have to use sprays again.
And those intermediary steps, like trying a breathe right strip or a snore bend, I think you labelled it, they're more of a stepping stone, a transition type approach?
Yeah, they are only really temporising measures. It's an option to wear one every night. Look, I've seen a handful of patients that have done that and they've stayed on. A snore bend is the most common one that people use in the long term. Some people use a breathe right strip every night, but most patients do seek a permanent solution. Usually, if you are finding that using either of those two products is what you need to breathe through your nose at night, then you will almost certainly need a functional rhinoplasty to improve that nasal valve and just give your nose the maximum opening which is possible.
And then on the other side of procedures, if people need to go down the surgical pathway for resolution of the nasal obstruction, and you suggested to me immediately almost upon using the scope, I'm just going to need, I think you said you're going to need a surgery. And I was already mindful that would probably be the case, thinking this can't be normal, but whatever normal is. But Dan, what happens post-procedures? I've heard you mention that it takes some time for the nose to restore itself, if you like, to normal, I guess, physiological functioning?
Yeah, so we know that from a purely physiological function, it takes, after an operation, it takes circa 12 months for the nose to return to complete normal physiology. Now, 90% of that is back to normal after 3 months post-op. And to be honest, very few people notice a difference between 3 months post-op out to a year. So essentially, although patients will have their nose defunctioned and it won't be working from a physiological point of view for a whole year, 100%, they only really notice it for 3 months. Now, in that 3 month period, it is as important as the operation to use a saltwater wash in your nose. That serves two purposes. One is to flush any debris out of the nose, and two is also to enhance the healing of the scar tissue within the nose, which is caused from the operation, and ensure that that's all washed away. And after patients have done that for 3 months, it's pretty rare that people really need to use the wash much beyond that.
If you missed last week's episode, it was an expert edition featuring positive psychology researcher and mental skills coach Rory Darkins on all things positive psychology for the endurance athlete. Here's a little snippet of my conversation with Rory.
I hadn't met an athlete who had seriously invested in breathing. Yet, when we look at endurance sport, the main system that we're working with is cardiorespiratory system, and it's often our breathing is what the limiting factor in terms of can we keep going at a certain intensity.
So to enjoy the full episode 252, and the many learnings that so many people have been talking about and sharing online from Rory, jump over to wherever it is that you enjoy your podcasts from, and also now available over on YouTube. For now, let's jump back with this week's expert edition, Dr. Dan Robinson, ENT Surgeon, on all things navigating nasal obstruction. Dan, allergies, etc. Is anything you'd share around people suffering from allergies and how that may affect nasal obstruction?
So, bad allergies manifesting in the nose manifests as hay fever, otherwise known as allergic rhinitis. The allergic rhinitis can be divided into two subsets. There is mild allergic rhinitis and then moderately severe. And the way that is defined is that moderately severe allergic rhinitis causes problems associated with sleep or work or school. As a general rule of thumb, if you have allergic rhinitis that causes problems with sleep, work or school, you really need treatment. It's having a very large impact on quality of life. If you have mild allergic rhinitis, then you can either choose to treat it or not. But if you have moderately severe, you really should. Now, the first-line treatment for allergic rhinitis is to try to avoid the allergy or the allergen, which is causing the allergic response. That can be easier said than done, especially if you're allergic to house dust mites, which is the commonest allergy that patients have with allergic rhinitis. people do things like using what's called arachicides in their bedroom, taking out the carpet, putting down floorboards, changing a house dust mite protected pillow, changing their mattress to a house dust mite protected mattress. A Cochrane review, which was done several years ago, demonstrated that all of these bedroom interventions, for want of a better word, may improve things, which is a lot of effort to get a result that may improve something. The next step with allergic rhinitis would be to move on to nasal sprays, intranasal steroid. And I think from a personal perspective, I feel that the medium to long-term goal in all patients with allergic rhinitis is then identification of the allergy and then treatment of the allergy with immunotherapy. Now, immunotherapy has been demonstrated to have a statistically significant reduction in symptoms associated with allergic rhinitis, which is maintained for a whole decade after treatment. Immunotherapy in our practice involves injection immunotherapy, which is an injection that you have once a month. Also has the knock-on effect of if you do have upper airways inflammation in the form of asthma, it does also make that better as well from an allergy point of view. Those are the treatment. That's the treatment regime which I implement for patients with allergic rhinitis. And then also, if they have a blocked nose as well, somewhere in there, we'll often do an operation to improve the breathing through the nose, understanding they still need to have their allergy treatment.
And how long might they need monthly injections for?
The monthly injections goes for 3 years, and then after 3 years, they can stop completely.
But it's a 10-year or thereabouts improvement.
It's been demonstrated to be a 10-year benefit after the 3 years.
Dr. Dan, I think you've really shone some great light and learnings here around the importance of identifying potential nasal obstruction. And we're not just talking about performance here, we're talking about people's health and well-being and all the domains that then flows over onto. Every guest of the show issues listeners with a physical challenge for the week. So I'm curious what Dr. Dan Robinson, ENT specialist, physical challenge is going to be.
I'm going to give the listeners two. So one is associated with breathing through your nose. As you're going to sleep tonight, I want you to try to lie there with your mouth closed and see if you can comfortably go off to sleep with your mouth closed. If you can't, then you almost certainly have a blocked nose, which is contributing to poor sleep. And the second is an exercise which at the moment I am wrestling with, and that's 1 hour on an assault bike, aiming to do 1,000 calories.
1 hour on the assault bike, 1,000 calories. How close to that are you, Dan?
I'm not sure I'll ever get there given my last attempt, but I'm at 780 at the moment. So, but analysing how to get the last 220 out of me, I don't know if I've got it.
You'll need every bit of lung volume there.
Yeah, I will.
You might need a good ENT surgeon.
Yes.
Dr. Dan, just before we talk about where people can find out more, look at your resources, etc., there's been, I think anyone in the field of performance would certainly note that there's a bit of a movement, if you like, around breathing and the importance of the breath. Anything you'd add to that? What's do you think spawned the emergence of this and some greater awareness around the importance of breathing and the quality of it?
There's no doubt that there's been a real surge in interest in this based on people that are able to perform at levels which are far beyond everyone else. And although they are anecdotal, a lot of those examples in the main media, such as Wim Hof, people have started to focus on why those people feel that they can perform so well, just because they breathe in a different way. So I feel that that's why it's really come to the fore. And when, from my own perspective, when you can breathe better when you're asleep, you recover better. And that's the key. Breathe better when you're asleep, you recover better. The other benefits associated with a small improvement in lung capacity and things like that, they are truly, that's been my experience and other patients' experience, but I don't have any hard evidence to back that up. But there's no doubt when you sleep better, you recover better, and if you breathe through your nose, you will sleep better.
We've featured several times on the show, Dr. Dan, Shona Halson, PhD, former recovery director for the Australian Institute of Sport across 3 Olympic Game cycles. And Shona has an adage, the only training you are benefiting from is the training you are recovering from. And then she has her recovery pyramid, and sitting at the very base, as in the most important part of that, is sleep and then nutrition, sleep and nutrition. And then she talks about all the other fads and different things that can come and go. So as you just said, it's about breathing better when you sleep and recovering better, and that flow on effect. Dr. Dan, where can people find you, your services, the clinic, and the things that you do?
I'm in a group practice called ENT Clinics, based on the Gold Coast. I do have an Instagram account called at dr.danrobinson, as well as 2 websites, goldcoastrhinoplasty.com.au and drdanrobinson.com.au. That's how patients can contact me.
Every guest summarises their career learnings to date, which is a huge challenge, into one single piece of advice that they would espouse to help listeners of the show perform at their physical best. So, what is Dr. Dan Robinson's solitary piece of advice going to be?
That's a very big question. So my one piece of advice to patients, to everyone, all listeners in relation to nasal obstruction, is to pay attention to whether you're breathing through your nose, and in paying attention to it, understand that if you have problems with breathing through your nose, it's something that you should get fixed or at least looked at, because if you can't breathe through your nose, you're probably not performing at your best.
And hearing that, I do reflect on some of my own recreational sporting pursuits, and maybe I underperformed for 15 odd years, maybe longer. So, oh well, it's better to start late than never, right?
Yes, yeah, indeed.
Brilliant, Dan. Thanks for stopping by. It's an incredibly busy week for you every week, so we really appreciate you sharing your expertise.
Oh, absolute pleasure, and thanks for having me, Brad. It's been very informative.
So there you have it, another episode of the Physical Performance Show, and I trust and I know you found today's sharings from Dr. Dan Robinson very interesting and, of course, very practical and informative. We will tag all of Dr. Dan Robinson's handles up in the show notes over at Pogo Physio if you do want to get in touch. And I urge you, as someone who suffered in silence for far too many years, if you are having trouble breathing through your nose, as Dr. Dan Robinson outlined, then please do something about it. It makes such a big difference to your well-being. I'm waking up 4 months post-surgery now, feeling so much fresher than I was when I could barely breathe through my nose. So I implore you, take action, reach out to Dr. Dan Robinson if you're in Southeast Queensland, or if you're looking for a great person to assist you in your immediate area. A massive thanks to those leaving ratings and reviews for the show over on iTunes, and for those hitting subscribe, which ensures the episodes go live into your earbuds each and every Thursday evening as we push play. Don't forget, if you would like to support the production of the show, we've now made that available over on Patreon. Just search the Physical Performance Show on Patreon, Patreon, and there you can pledge your support for just $5 per month and receive access to the back catalogue and all upcoming live stream events. And of course, if you are an endurance athlete struggling with bone, tendon or joint related concerns, looking to get back to your physical best, then jump over to pogophysio.com.au/telehealth to schedule your 45-minute online consultation where myself or one of the physio team here at Pogo can assist you in getting back to your best. A massive thanks to the great folk who make the Physical Performance Show possible each and every week. Daryl Misson, our audio engineer, Susan Wilkin on all things show administration, and Matthew Walding on all things show graphic design. Don't forget to keep the podsies coming. They are always so much fun. Simply tag in at Physical Performance Show on Instagram, and check out the Facebook page and follow along on YouTube if you would like. You'll also find the show over on Twitter, Facebook and YouTube. Now, coming up on next week's episode of the Physical Performance Show, I'm so excited to share with you an expert edition around all things how to navigate your taper. Now, we've lined up arguably the world's preeminent expert in this field, Inigo Mujica from Spain. Inigo is a sports physiologist, triathlon and swimming coach, the associate editor for the International Journal of Sports Physiology and Performance, an associate professor and researcher, and the author of Endurance Training, Tapering and Peaking for Optimal Performance, and the World Book of Swimming from Science to Performance. Here's a little snippet of my conversation with Inigo.
24 hours before Eneko Llanos won that long distance world championships. And 24 hours before the race, I sent him a text message. How do you feel? And he said, I'm very relaxed and well rested. I have great sensations and I'm competition hungry. That's the exact sentence that he said. That is a good description of how an athlete should feel if everything is going well in the lead up to competition.
So be sure to be tuning in next week to catch Inigo Mujica, leading expert around all things how to get your next taper right. Until then, keep pursuing your physical best performance. I'm Brad Beer, and this has been the Physical Performance Show.